I'm going to talk about the antithesis of this. It's a topic on I would say, not quite everybody's mind, but it's really the radical new thing, novel approach in rectal cancer treatment that suddenly has gained traction after many years of being just a Brazilian concept. They do it down in South America, and maybe they're getting away with it. But can we actually treat rectal cancers without operating? So despite the beautiful surgery, why do we not want to operate? Because major pelvic surgery has major complications and major quality of life issues. So there's a low risk of dying, there's a significant risk of leaks, significant risk of reoperations. I put variable for sexual and urinary dysfunction. It depends on so many factors, age, sex, radiation, but we know those numbers are high and almost always underreported. So it's a serious problem. And the functional results after you've had an anterior resection for rectal cancer are really not that good. So you almost don't have to read any of the legends here. You just have to count actually the red bodies. This was the colors did not come out right the way the authors wanted in my journal. But anyway, bad things happen in terms of low anterior resection syndrome, severe low anterior resection syndrome that get worse the lower you go on the rectum and when you give radiation therapy. So if you have a low rectal cancer that's been radiated, you get put back together, you have a very substantial risk of having very poor functional outcomes, which is a real lifestyle issue. And finally, there's the stoma issue. So even if we can save the sphincter in many cases, most cases, we can save the sphincter. Almost all of those have at least an ileostomy. This is actually a propensity-score matched cohort looking at watch and wait, but which I don't want to get ahead of myself, but you can see the colostomy-free survival much, much higher if you don't go poking around at the rectum. Way better. And that's an issue. So the idea of organ preservation is not new. So here's Norman Nigro, I don't know, probably 1970, Stan, would you say? That when he came up with the idea, so before that, it's in some of our lifetimes, you had an anal cancer, you got an abdominal perineal resection. And then with the advent of chemoradiation, these tumors seem to disappear. That's very routine in our thinking now. We see somebody with anal cancer, we treat them, we expect it to be gone. The great majority of the time it is gone, but not proceeding with surgery was a gigantic leap of faith back then. It took some time to take hold, but now we accept that. So, of course, Angelita Habrugama in Brazil is the one who actually had the courage to advance the same argument for rectal cancer, that if you give neoadjuvant treatment and there's no tumor left, what do you gain by removing that? And so she published a paper back, this is 15 years ago. It's a much smaller trial, but you can see they were just observing patients who had a clinical complete response to their neoadjuvant therapy, and you can see that they had really excellent 5-year survivals. Very impressive results. And she appropriately raised the question. The absence of residual cancer cells in the resected specimen raises the question why surgery is appropriate if you're not removing a single cell of cancer. Really great question. So what's happened in the last 15 years that has made people start to buy into the watch and wait concept? Well, there's two things. First of all, as Wolf just showed, we have improved neoadjuvant therapy. So we have a better way of driving clinical complete responses. And there are a lot more data available. It's not just telling the patient, well, there's this crazy woman in Brazil who's doing this and getting away with it, but there actually are data available. So just a couple of words on neoadjuvant therapy. This is the timing trial. When Julio Garcia Aguilar was originally cooked this up, it was really just about the delay to surgery. It's actually kind of interesting how this evolved. That he just wanted to find the ideal time when the tumor was at its nadir and you could take out, it was the right time to time surgery. And the medical oncologist felt uncomfortable leaving patients, quote, exposed to their cancer without giving some adjuvant therapy. And it sort of got negotiated out when they were forming up the trial, and they agreed to give these bursts of Folfox, cycles of Folfox, during the waiting period, just so nothing bad would happen, try and protect the patients. But unexpectedly, that turned out to be a really important thing. And you can see that if you start with this was timing group, the group 1 was how we were doing things, giving the neoadjuvant chemoradiation, waiting and operating, 18% pathologic complete response. And as the time went out, adding in more Folfox, the pathologic complete response rate went way up, almost to 40%. It's really dramatic. While that was going on, this is the Angelitas protocol that they cooked up. They wanted, when they got into the idea of not operating, they wanted to give more aggressive therapy to see if they could get complete responses on more patients. So they added something that's conceptually similar. They boosted the radiation a little bit, but they added more chemotherapy, and their results improved substantially, which I won't get into right this sec. And this, again, is the Sloan Kettering data that Wolf showed about the adoption of total neoadjuvant therapy. And you can see with this, looking for complete response, which was defined as either a pathologic complete response for people who were resected or a 1-year clinical complete response. You can see that for stage 2 tumors who get TNT, over half of them, the cancer goes away. So stage 2, those are these T3N0 cancers. We see a lot of those. Stage 3, they do very well, and overall, the complete response rate is a third of patients or more. So it's a pretty dramatic response. So our chemo is better. We can get people to a place where they have a clinical complete response or a complete pathologic response. As a practical matter, how do you do this? So I would emphasize, we've got this going here. We are up to 25 patients now in our own little series, but the numbers seem to be mounting fairly rapidly since we've added TNT into our basic protocol. You have to have a plan, and you have to take responsibility for these patients because there is a significant regrowth rate, I'll show you. So you have to have a protocol that you're comfortable with. You have to have buy-in from your team members. You have to make sure the patients show up and get checked so that you don't do harm. So what are the endpoints? Digital exam. So originally in Brazil, it was only for tumors that were within the reach of your finger. We are not insisting upon that here. I think proctoscopy, we should get rid of all of the proctoscopes, throw them away, melt them for almost everything. Sorry, Stan. But you need a good quality flexible endoscope so you can really look at where the scar is and see it well. You need good MRI. You need to make sure there's no distant mets occurring, of course, and we follow CEAs. So this is our protocol here, and you can see it is fairly labor intense. We're paranoid about this. Sigmoidoscopy, very frequently. MRIs, very frequently. The CT is looking for distant disease. We don't do as frequently. Colonoscopy is per routine. But we look very carefully. This is what you want to see. It is a soft white scar. There's some telangiectasias there. There's no ulceration. If it's in the range of your finger, it should feel smooth and soft and healthy. MRI is critically important. Now, for those of us who have, well, for everybody, when patients are referred who have had a pelvic MRI, the quality of the MRI is very variable, and the quality of the reporting radiologist is actually quite variable as well. So this is not a job for a general radiologist who reads pelvic MRIs, once a month once every 2 months. You need a dedicated radiologist because these are subtle calls, and you're really depending upon them to make sure that your response, your clinical response, is complete. So here's one of our patients just to show you. The top line, the top row is the pretreatment pictures, and you can see a T3 tumor. There's, if I can get an arrow on there or not. Maybe? No. Yes, okay. This is a T3 tumor. You don't have good definition between the rectal wall and the mesorectum. Here it is in the lateral view. This is the post-treatment. You can see the anatomy of the rectum is restored. You can see the rectal wall looks thick, so this is a radiated rectum. This does not have any tumor signal in it, so we count on our radiologist to tell us this is not tumor signal, this is edema. We believe that's what it is. And you can see just to the right there, this lateral view, sharply defined borders. But there is no tumor here. This is a clinical complete response. But you must have those things in place, and you must have a plan for keeping an eye on the patient. I think that's so important. This is a minor point, but we do have patients who seem like they're almost there when you examine them. When they come back, typically we'll re-examine patients about 8 weeks after they've completed their chemoradiation. When they're almost there, we'll let them go a little bit longer. This is again from Brazil, and they actually let patients go quite a bit longer after completion of their radiation. It works out a fair amount of the time. I'm not really advocating this, but there is a role for letting these things evolve because it does take time for the radiation to work. So, what are the data? This is the International Watch and Wait database run by Gerhard Beetz. It's a little bit of a heterogeneous group. You don't really know exactly who are putting their patients in, so I think it differs from some of the other series where there for sure are dedicated centers that have their act together. So I think some of the results are not as good as you might expect, but they have 880 patients. They have some sort of moderate follow-up. The regrowth rate is actually 25% in this series, which is a little bit higher than you see from Brazil or elsewhere. The issue about that, the official nomenclature for this, according to the Brazilians, that is kind of getting adopted, is that if the tumor is back within a year, that's a, quote, regrowth. If it's after a year, it's a recurrence. It's something of a semantic distinction. But anyway, 25%. It's almost always up front in the earlier time frame, and it's almost always located in the bowel wall. The issue of distant metastases is actually an interesting one. So to me, if you do watch and wait, the patient crops up with a liver met 2 years later or a year later, whatever it is, that's a win for watch and wait because you have not resected, you haven't put the patient through an anterior resection that I believe would not have influenced the occurrence of those liver mets. If you believe that it's micrometastatic disease present at the time of your operation, not taking out a healthy rectum doesn't gain you anything. And that's how I choose to look at it. Not everybody does. Christine, am I out of time?
You're 1 minute.
Okay, there we go. Let's skip that. Let's go to this. These are the survival curves from the registry. They look pretty good. Those blue lines are way up near the tops of the graphs. Obviously, there's no comparison group in this, so you say, what would have been achieved if we'd taken out these tumors? So I'll offer for comparison. This is a study of patients who have had a pathologic complete response based on their radical resection. And I would say that the patients, so the red is the pathologic complete response, the blue is the non-complete response. You get a pathologic complete response, you do better, but that doesn't guarantee that you're cured. Taking out that, doing an anterior resection or an APR in somebody with a pathologic complete response, they even still have in the upper left graph local recurrence rates. So it doesn't guarantee, taking out doesn't guarantee that there won't be a local recurrence. This is propensity match study shows basically that the equivalence of watch and wait and resections in this group. All right, this is probably the best data. This is from Nancy Baxter, did a meta-analysis, looked at, compared watch and wait to either a clinical complete response that underwent surgery, or patients that underwent surgery and turned out on path had a pathologic complete response. The pooled regrowth rate is more like 16%. I think that's more realistic. I think these were more specialized centers doing this and reporting it rather than the registry. Salvage surgery is a critical issue. You have to be able to salvage these things with the regrowth. So almost everybody who has a regrowth is able to undergo salvage. And when you look at the reasons why they don't, some patients just refuse surgery. Some are too unhealthy in the first place to have surgery anyway. A variety of reasons, but great majority of people have surgery. And the thing that we worry about while we're waiting, that tumor is going to grow all of a sudden and start involving the pelvic sidewall, and we're not going to be able to resect it. That's quite rare, as long as you're watching the patient. So the real downside is not a very high risk. Again, from the same paper, everything looks equivalent. The recurrences. Disease-free survival is worse in watch and wait because there are these regrowths. But in terms of overall survival, cancer-specific mortality, no difference between resecting and watching and waiting. So, what are wrong with all these things? There are no randomized trials yet. It's still a limited experience, but the numbers are growing rapidly. The data are heterogeneous. How this applies from centers of excellence, where people are really paying attention to this, to people that might be doing it less often or in a less committed fashion is uncertain. We don't have perfect data, very good data on the salvage outcome, or very long term. So is watch and wait ready for prime time? In my own personal opinion, for the surgeons, why should we watch and wait? Let's get involved. Thanks very much.